Have you ever wondered why, in the wealthiest country in the world, getting sick can leave a person penniless? This is a great paradox, an American paradox, where the country leads in medical technology but millions of its citizens still do not receive decent health care. This is a question I have always pondered. We will begin this journey with a story. Imagine a friend of yours in the U.S. breaks their arm. Instead of worrying about the pain or the recovery process, the first thing he thinks about is the hospital bill. It's just one broken arm can put a middle-class family on the brink of bankruptcy. This is a harsh reality, a phenomenon called medical bankruptcy, a characteristic unique to the U.S. So, why does this paradox exist? Why has health, a basic human right, become a luxury item? In a country where healthcare costs account for nearly 20% of GDP, the highest in the world, millions of people still live in fear of illness. To find the answer, we will go on a journey of discovery from history, the reasons for the high costs, the injustices in the system, to the challenging reform efforts and an uncertain future. Join me to find out why in the U.S., illness is such a financial burden. Imagine a day when you don't have to worry about the cost of a doctor's visit. Could that happen in the U.S.? Join me in finding the answer by hitting subscribe and embarking on this journey of discovery. Origins: a nation without a national healthcare system. Welcome back to the American Paradox series. In the introduction, we revealed a harsh and ironic truth. Illness in the U.S. is not just a health challenge, but can also be a heavy financial sentence, pushing millions into bankruptcy or deep debt. Imagine a middle-class family facing a hospital bill of hundreds of thousands of dollars for a single, unexpected surgery, forcing them to sell their house or take out loans to pay the debt. So why did an economic superpower like the U.S. put itself in such a precarious position? The answer is not in a single event or a single wrong decision, but is the result of a long historical journey. Full of unexpected decisions, choices that seemed reasonable at the time, and random factors that have intertwined to create the complex, fragmented, and most expensive healthcare system in the world today. To better understand, we need to go back in time, exploring each important turning point. From the early days of modern medicine to wartime economic policies, and comparing it to the path other nations chose, let's start from the early 20th century, an era when healthcare was a far cry from the massive industry it is today. In the 1900s, medicine was still in a primitive stage, and sometimes more superstitious than scientific. Treatments were often quite strange and lacked a scientific basis, such as using goat endocrine glands to treat chronic diseases, applying electromagnetic baths to stimulate the body, or selling snake oil as a panacea. These methods, despite their limited effectiveness, had one big advantage. They were very cheap and accessible, according to historical documents. Average healthcare costs for an American in 1900 was only about $5 per year, a modest amount, equivalent to about $135 in today's money after adjusting for inflation. At that time, most illnesses were treated at home with the help of local doctors or even folk healers. Hospitals were not yet common. They were often reserved for the poor, the homeless, or serious cases that could not be treated at home. The image of a hospital then was more like a charitable institution than a modern medical facility, with poor sanitation and high mortality rates due to infection. Everything began to change as the medical profession gradually became specialized. Medical schools in the U.S. in the early 20th century lacked clear standards, often missing essential facilities like laboratories or basic medical equipment. Many were just small training centers with uneven educational quality, leading to doctors lacking skills and scientific knowledge. The founding of the American Medical Association in 1847 marked a crucial turning point. The AMA not only promoted scientific research but also strove to improve medical education, aiming to raise professional standards. The culmination of this process was the Flexner Report in 1910, conducted by Abraham Flexner, an educator commissioned by the Carnegie Foundation. This report harshly criticized the chaotic state of American medical education, proposing stricter requirements for admissions, modern facilities, and higher tuition to ensure quality. As a result, hundreds of low-quality medical schools were closed, and only about half remained, By 1920, the prestige and income of doctors had skyrocketed, transforming them from independent practitioners sometimes looked down upon into a high-status profession in society, with average incomes much higher than in other fields. However, this professionalization also had a natural consequence. Healthcare costs began to escalate. As services now required more advanced technology, more specialized training, and expensive infrastructure, this created an urgent need for a form of insurance to help people pay for increasingly expensive medical services. Although there were early efforts to build a universal health insurance system, all failed due to opposition from many sides. A prime example was the proposal by the American Association for Labor Legislation in 1915, calling for mandatory health insurance for workers, inspired by European models like Otto von Bismarck's system in Germany. Initially, the AMA also supported this idea, seeing it as a way to expand access to care. However, by 1920, the AMA had withdrawn its support, mainly out of concern that government insurance would interfere with doctors' professional autonomy and reduce their income. This opposition reflected a core American philosophy, prioritizing individual freedom and the free market over government intervention. Other efforts, such as President Theodore Roosevelt's proposal in the early century, also sank amid a conservative political climate and the influence of interest groups. It wasn't until the late 1920s, when healthcare costs truly became a burden, that rudimentary insurance models gradually formed. The first breakthrough came from Justin Ford Kimball, a hospital administrator at Baylor University in Dallas, Texas. He realized that local teachers, a group with stable but not high incomes, often couldn't afford hospital bills when they had serious health problems. To solve this, in 1929, Kimball created an innovative plan. A group of 1,500 teachers would contribute 50 cents a month in exchange for a maximum of 21 days of free hospitalization per year at Baylor Hospital. This plan not only solved the financial problem for the hospital, but also was a resounding success, attracting thousands of participants and spreading to other states. It became the predecessor of Blue Cross, a nonprofit organization that paid for hospital bills and was quickly replicated nationwide. At the same time, in the Pacific Northwest, a similar model was born in the logging and mining industry. Business owners, concerned about the health of workers in a dangerous environment, paid a monthly fee to local doctors to provide medical services. This model later developed into Blue Shield, which focused on paying for doctor services outside of hospitals. These initiatives marked a shift from a self-pay model to a group insurance model, but they were still local and voluntary, not a national system. However, the biggest and perhaps most fateful turning point came from an event completely unrelated to healthcare: World War II. During the war, the U.S. government, under President Franklin D. Roosevelt, implemented strict wage controls through the War Labor Board to curb inflation and stabilize the economy. This meant that businesses could not directly increase wages to compete for and retain talent, leading to a severe labor shortage. Faced with this situation, companies found an extremely clever and legal backdoor, offering non-cash, non-taxable benefits such as health insurance. This decision was solidified by a 1943 ruling by the U.S. Internal Revenue Service, which confirmed that employer-provided health insurance was not taxed as income. It was an ironic and cynical coincidence. One of the country's largest social systems, affecting hundreds of millions of people, was created by chance just because of a temporary wartime economic regulation. As a result, health insurance became an important competitive benefit, helping companies attract employees without violating wage laws. By the end of the war, the number of people with health insurance through their jobs had tripled from about 12 million to over 30 million. Since then, the employment-based health insurance model has become the backbone of the U.S. healthcare system, creating a system dependent on the labor market rather than the government. While the U.S. went down this private path, in Europe, a completely different direction was chosen after World War II. Countries like the UK, France, Germany, and Sweden built universal healthcare systems where the government plays a central role. ensuring every citizen receives healthcare regardless of income, employment status, or age. In the UK, under the leadership of Health Minister Aneurin Bevan, the NHS was funded primarily by taxes, providing free services at the point of use, based on the principle of from each according to his ability, to each according to his need. Germany maintained the Bismarck model from the 19th century, with mandatory insurance, but managed by non-profit funds. This core difference created two opposing philosophies. In Europe, healthcare is considered a basic human right, protected by the state. While in the U.S., healthcare is a market service, dependent on a person's ability to pay and benefits from their employer. This reflects a deep cultural difference. The U.S. prioritizes individual freedom and competition, while Europe emphasizes social equality and the role of the state. By the 1960s, the gaps in the U.S. healthcare system had become clear and could not be ignored. The elderly, the poor, the unemployed, or the self-employed, those without stable jobs or employer-provided insurance, were completely left behind, leading many to delay treatment until their illness was severe, which increased overall costs. This prompted a political debate that lasted for decades about healthcare reform. President Harry S. Truman, right after World War II, tried to pass a universal healthcare bill in 1945, but it met with strong opposition from the AMA and conservative groups, who accused it of being socialized medicine like communism. The bill failed, but the seed was sown. 2 decades later, under President Lyndon B. Johnson, in the context of the Civil Rights Movement and the Great Society, a major step was taken. On July 30th, 1965, Johnson signed the Social Security Act of 1965 at the Truman Library in Independence, Missouri, creating 2 historically revolutionary programs. Medicare provides health insurance for people over 65. Some people with disabilities under 65, and those with end-stage renal disease. This program is divided into parts: Part A, Part B, and later Part D. It is funded by payroll taxes and premiums, helping millions of elderly people avoid bankruptcy due to illness. Medicaid provides insurance for low-income individuals, pregnant women, children, and those who need long-term care, such as the disabled or the poor elderly. This program is co-managed by the federal and state governments, with coverage varying by state leading to geographical inequality. Notably, Harry S. Truman, who had failed in his initial effort, was the first person to be enrolled in the Medicare program, receiving Medicare card number 1 from Johnson, a symbolic gesture of persistence. Although Medicare and Medicaid have helped millions of people, they are still just temporary patches that have not changed the private and fragmented nature of the system. Both programs grew faster than expected, with costs soaring due to medical inflation and an aging population, leading to many cost containment measures later on, such as cutting payments to doctors or limiting services. Thus, from a simple system where patients paid all costs themselves, the U.S. went through a complex and surprising historical journey to form the healthcare system of today. A wartime accident created the employment-based insurance model, while other countries chose the path of universal, government-managed healthcare. This created a system unique in the world, where losing a job does not only mean losing income, but can also mean losing health security, pushing people into a vicious cycle of debt and inequality. This difference is not just theoretical, but is clearly seen in reality, with the U.S. having the highest healthcare costs in the world, but not commensurate health outcomes, such as a lower average life expectancy compared to other OECD countries. Was linking healthcare to employment a genius idea that boosted competition and innovation? Or was it a tragic start that created deep inequality? Do those who are lucky enough to have a job and insurance truly escape the financial burden? The answer lies in the massive hospital bills and the social consequences they bring. Join me to explore this in more detail in the next part, where we will analyze the current shortcomings, from escalating costs to the interference of insurance companies, and see if there is any way out of this American paradox. The rise of employment-based insurance. Welcome back to the journey of exploring the American healthcare system, a maze full of surprises, where seemingly small decisions lead to major consequences that shape the lives of millions. In the previous part, we saw how a wartime economic regulation accidentally laid the foundation for the employment-based health insurance system, a model unique in the world. This is a system where the health insurance card is not just a tool for health protection, but also a symbol of career stability. But is this model truly a genius solution, or is it just a sugar-coated poison pill, bringing short-term benefits but leaving behind persistent problems? Let's dig deeper to find out. Let's go back in time to the years after World War II, when the U.S. was entering its golden age of economic development. In this context, the employment-based health insurance system became a major boost, helping to quickly and effectively expand health insurance coverage, instead of each individual having to find and pay for insurance themselves, a risky and expensive task at the time. Companies took on the role of intermediaries. They negotiated with insurance companies to provide group insurance plans for employees, often at a much lower cost than individual insurance. The result? Tens of millions of American workers and their families suddenly had access to medical services that were previously only available to the wealthy. From routine doctor visits and child vaccinations to complex surgeries, health insurance became a safety net that gave workers more peace of mind about the future. For companies, providing health insurance was also a way to attract and retain talent. In the 1950s and 1960s, a good job meant not only a high salary, but also a generous benefits package, with health insurance at its center. This system also brought great benefits to insurance companies and hospitals. Insurance companies gained a large, stable customer base from businesses, while hospitals received a steady flow of money from insurance payments. In short, this was a win-win model, at least on the surface. It helped the U.S. build a strong private healthcare system, with modern medical facilities and advanced technology becoming a model for many other countries. But like any story, the glory always comes with shadows. This system, while effective at expanding coverage, unintentionally created major gaps that only the most vulnerable felt the harshness of. Imagine you are John, a middle-aged worker, living in the suburbs of Chicago. John has worked for a car manufacturing company for over 2 decades. He has a small family with 2 children of school age and a wife with a chronic illness that requires regular treatment. John's job not only brought him a stable income, but also provided a generous health insurance package, covering everything from medication to regular checkups. For John, health insurance was like a life raft, ensuring that his family didn't have to worry about expensive medical bills. Then one day, John's company announced a restructuring. The car market was struggling, and John, along with hundreds of his colleagues, was laid off. Suddenly, he not only lost his source of income, but also his medical safety net. His wife needed urgent surgery, but the cost was up to $50,000, an unimaginable amount for a family that had just lost its job. His youngest son needed medication for asthma, but each bottle now cost hundreds of dollars without insurance coverage. John's nightmare was not just losing his job, but the collapse of the entire medical security system his family depended on. John's story is not a fabrication. It reflects the reality of millions of Americans, where the employment-based health insurance system has created a cruel paradox. Losing a job means losing insurance, while countries with universal healthcare systems like Canada, the UK, or Germany ensure that all citizens have access to medical services regardless of their employment status. Americans are trapped in a system where their health depends on a labor contract. The consequences of this model are not limited to individuals like John. It has created a deep social stratification, where access to health care has become a privilege of those who are lucky to have a stable job. People who work for large companies, especially in tech, finance, or law, often receive comprehensive insurance plans that cover everything from dental care to cancer treatment. In contrast, freelancers, part-time workers, or those in low-wage industries, such as retail, food service, or construction, often do not receive similar benefits. Let's look at some numbers to get a clearer picture, according to a 2023 Kaiser Family Foundation report. About 60% of Americans get health insurance through their job or a family member's job. However, only 50% of small companies provide health insurance compared to 99% of large companies. This means that people who work for small businesses or are self-employed often have to buy insurance on the individual market, where the average cost for a family of 4 can be up to $20,000 per year, a sum many cannot afford. Moreover, this system exacerbates racial and socioeconomic inequality. The poor, people of color, and immigrants often have less access to jobs that provide good benefits. For example, a 2022 study by the Centers for Disease Control and Prevention showed that 20% of African Americans and 30% of Hispanic Americans lacked health insurance, compared to just 8% of non-Hispanic white Americans. These numbers not only reflect employment disparities, but also show how the employment-based health insurance system unintentionally reinforces social inequality. Recognizing these problems, there have been many attempts to reform the U.S. healthcare system. But each step has faced major obstacles. One of the most notable reforms is the Affordable Care Act, also known as Obamacare. It's passed in 2010. The ACA tried to solve the problem by creating marketplaces, where people could buy individual insurance with government subsidies. In addition, the ACA required large companies to provide health insurance to employees, and also expanded the Medicaid program to help low-income people. However, the ACA was not a silver bullet. Many people still couldn't afford insurance on the marketplace, especially those in the lower middle class, who weren't poor enough to qualify for Medicaid, but also not rich enough to buy quality insurance. Furthermore, insurance companies and hospitals, powerful interest groups, have constantly lobbied to protect their profits, making radical reforms difficult. For example, the idea of a universal healthcare system, supported by some politicians like Bernie Sanders, met with fierce opposition from insurance companies, private hospitals, even some unions who were concerned that a transition to a public health system would eliminate the benefits packages they had negotiated. The story of the U.S. healthcare system is not just about policy, also about power and money. Insurance companies with hundreds of billions of dollars in revenue each year have a strong incentive to maintain the status quo. Private hospitals and clinics, which depend on insurance payments, also do not want to change a system that brings in huge profits. Meanwhile, workers, especially those in the lower classes, become pawns in a larger game, where their health is tied to labor contracts and economic policies. This system also creates another paradox. Even those who are lucky to have insurance through their job are not completely safe. Healthcare costs in the U.S. are skyrocketing every year, faster than inflation or wage increases. According to the Kaiser Family Foundation, the average insurance cost for a family of 4 increased from $13,000 in 2009 to over $2,000 in 2023. Even with insurance, many people still face high co-pays and deductibles, causing them to hesitate to seek medical care when needed. The employment-based health insurance system has shaped the U.S. for more than half a century, bringing benefits to millions, but also leaving deep cracks in society. Those who are lucky enough to have a stable job may feel safe, at least temporarily. But for the unlucky, freelancers, those who are laid off, or those who never get the chance to access a good job, this system is like a game of chance, where their health and life are on the line. So how can we move towards a fairer future? Is it possible to separate health insurance from employment, as many other countries have done? Or will the U.S. continue on its own path, with minor reforms within an already overly complex system? These questions are not just about healthcare, but also about fairness, opportunity, and how a society chooses to care for its most vulnerable members. In the next part, we will delve into why the U.S. healthcare system has become so expensive, and why even those with insurance can fall into debt because of medical bills. Let's explore the next hidden corners of this story. Why is U.S. healthcare so expensive? Welcome back to the journey to decode the American healthcare paradox. In the previous part, we explored a harsh reality. Even if you have a stable job and a good insurance package, a sudden health event can still wipe out all your assets. Now, let's dig deeper into the core question. Why has the U.S. healthcare system become such a massive, money-consuming monster? The answer is not in a single factor, but is a complex combination of several main pillars, built on a foundation of money, political power, to an administrative messiness that is hard to believe. We will analyze each pillar in detail with real-world examples and data updated to 2025 to get a clearer picture. This system is not only expensive but also inefficient, leading to serious social consequences that we will address later. The U.S. healthcare system operates on the principle of a free capitalist economy where the market is supposed to self-regulate. However, in the field of healthcare, where the product is human health and life, this freedom leads to major problems. Unlike other markets, where consumers can compare prices and choose, patients often do not know the real cost until they receive the bill. This allows large pharmaceutical companies to arbitrarily price their products, especially those protected by patents. Let's take the typical example of insulin, an essential drug for more than 34 million Americans with diabetes, according to data from World Population Review in 2025. The average price of a vial of insulin in the U.S. is about $98.70, many times higher than in other countries. In contrast, in Canada, a neighboring country with a stronger public healthcare system, the price is only about $12 for a similar vial. This difference is not due to higher production costs, as insulin was invented more than 100 years ago, and the actual production cost is only a few dollars. Instead, the main reason is extended patent monopolies, which allow companies like Eli Lilly or Novo Nordisk to set exorbitant prices without government intervention. Not only insulin, but many other drugs suffer the same fate. For example, Ozempic, a popular diabetes and weight loss drug, costs about $936 per month in the US, while in Japan, it is only about $169, according to a 2025 report from Canadian Insulin. The reason? The US government, influenced by pharmaceutical interest groups, is not allowed to negotiate drug prices directly with manufacturers, unlike most other developed countries like the UK, Germany, or France. In these countries, the government uses collective power to negotiate, leading to drug prices that are 50 to 80% cheaper. As a result, the US spends the most in the world on medication, accounting for about 40% of the total global healthcare expenditure. Despite having only 4% of the world's population, this lack of control not only increases costs, but also encourages pharmaceutical companies to focus on extending patents rather than on truly new drug research. If drug prices are the flame that burns wallets, then administrative costs are the smoldering underground fire, accounting for the largest share of total U.S. healthcare spending. The U.S. healthcare system is not a unified system, but a chaotic network with thousands of private insurance companies, each with hundreds of different product packages, along with countless unique payment rules. This creates a fierce paperwork war between hospitals, doctors, and insurance companies. Imagine a typical hospital in the U.S. In addition to the team of doctors and nurses, they need a huge administrative apparatus, including medical coders, billers, and even lawyers to handle disputes. Their job is to accurately code each medical procedure according to the ICD-10 system with over 70,000 codes, then match them with the rules of each insurance plan. Small mistake, such as a wrong code for a test, can lead to the payment request being denied, forcing the hospital to appeal multiple times. According to a study from Health Affairs in 2022, administrative costs in the U.S. account for about 15 to 30% of total healthcare spending, equivalent to over $1,000 per person, 5 times higher than in other wealthy countries. In comparison to Canada, where the system is simpler with public insurance, administrative costs are only about 3 to 7%, according to the Peterson KFF Health System Tracker in 2025. This waste is not limited to paperwork. Insurance companies often use a prior authorization strategy, requiring doctors to prove the necessity of a procedure, leading to treatment delays and indirect cost increases. A 2023 report from the Commonwealth Fund shows that the U.S. spends about $925 per person on administration, far more than other OECD countries. As a result, for every $3 to $4 spent on healthcare in the U.S., at least $1 is burned in the convoluted administrative machine instead of being invested in actual patient care. This not only increases bills, but also contributes to the burnout of healthcare workers, leading to a decrease in the quality of care. The U.S. leads the world in medical innovation, with advanced technologies like MRI machines, surgical robots, and gene therapy. However, this leadership comes at a steep price. Hospitals compete fiercely by investing in the most modern equipment. For example, an MRI machine can cost millions of dollars to buy and maintain. This cost is passed directly to the patient through higher service prices. According to the OECD, the U.S. performs more imaging tests than any other country, but this does not always lead to better health outcomes. In addition, salaries of doctors and medical specialists in the U.S. are exceptionally high compared to the rest of the world, according to the Medscape Physician Compensation Report in 2025. The average salary for a U.S. doctor is about $374,000 a year, twice as high as in Norway or other European countries. The main reason is the enormous cost of medical training. A U.S. medical student often graduates with an average debt of over $200,000, according to the Association of American Medical Colleges. To compensate, they need high salaries, leading to a vicious cycle. Expensive education drives up salaries, and high salaries increase the total cost of healthcare. Furthermore, the fee-for-service payment system encourages doctors to order more procedures than necessary, contributing to excess costs. All of the above pillars have pushed the U.S. healthcare system to be the most expensive in the world. Let's consider specific examples with 2025 data. Cost of childbirth. An uncomplicated vaginal birth can cost from $10,000 to $30,000, according to Forbes Advisor. Without insurance, the average is $18,865, 5 to 10 times higher than in the UK or Canada, where childbirth is almost free through the public system. Broken arm. A simple broken arm can lead to a bill from $2,500 to $16,000, according to Talk to Mira and other sources. This includes x-rays, casting, and follow-up. But if there are complications, the cost can exceed $20,000. These numbers not only affect the uninsured, but also burden those with insurance. Through high deductibles, co-pays, and co-insurance. Overall, according to Peterson KFF in 2025, the U.S. spends about 16.7% of its GDP on healthcare, far higher than the OECD average of 12.86%. For comparison, the UK spends about 11%, Germany 12%, and Canada 11%. But the average life expectancy in the US is lower. Spending twice as much but getting worse results shows that the system is inefficient. This high cost is not just a number on paper, but creates a real fear in society. Many Americans delay doctor visits for fear of the bill, leading to more severe illnesses and higher costs later on. Will this fear push millions into bankruptcy? And what will the poor and uninsured face? We'll explore the most tragic consequences in the next part. Bankruptcy due to illness and deep health inequality in the U.S. The human cost. Medical bankruptcy and inequality. Welcome back to the series on the U.S. healthcare system. In the previous part, we explored the three main pillars that make healthcare costs here so absurdly expensive. The lack of price control leading to unchecked inflation, cumbersome administrative machine with tons of unnecessary paperwork, and the high labor and technology costs that make every treatment a huge investment. Numbers like tens, even hundreds of thousands of dollars for a simple surgery are no longer science fiction, but a daily reality for millions of Americans. However, these dry statistics are only the tip of the iceberg. Behind every massive hospital bill are tragic human stories, persistent fear, prolonged despair, and sometimes the complete collapse of a once stable family. numbers cannot fully tell the story of the physical and mental pain this system causes. And we need to look deeper to better understand the true human cost. This is when we must face a phenomenon almost unique in the world: medical bankruptcy. Can you imagine that in an economic superpower like the U.S., where prosperity is celebrated as the American dream? Millions of citizens still live in terrifying fear of illness. They don't just fear death or the pain from disease, but are even more terrified of the hospital bills that could wipe out their entire lives in the blink of an eye. A famous study from Harvard University published not long ago revealed a stunning truth. Healthcare costs are the leading cause of up to 62% of personal bankruptcies in the U.S. And what's even more frightening is that among those pushed to this breaking point, up to 75% had health insurance when they fell ill. This is not a minor loophole, but a cruel irony of the system. It not only leaves behind the uninsured, the poorest in society, but can also swallow up the middle class who have carefully invested in insurance, thinking they were protected. These numbers are not random. They reflect a system designed to prioritize profit over human health, where insurance companies often try to minimize payments by applying complex terms, leaving patients to bear the majority of the costs. To illustrate this more clearly, let's delve into the story of a typical middle-class family, a story built on the most common real-life situations. Inspired by thousands of similar cases documented in studies and reports, imagine the family of John and Sarah living in a peaceful suburb of a large city like Chicago or Los Angeles. John is a software engineer working for a tech company, with a stable salary of about $80,000 a year, while Sarah is a high school teacher, earning about $50,000 a year. They have 2 small children, an 8-year-old boy and a 5-year-old girl, and a monthly mortgage of about $2,000. Their life seemed perfect. They had a good health insurance package provided through John's company, with a deductible of $5,000 per year, and copays for specialist services of about $20 to $30. They even had a small savings account of about $20,000 for emergencies, and were planning their annual family vacation. But then disaster struck unexpectedly. Sarah, at age 40, suddenly felt prolonged fatigue and was diagnosed with early-stage breast cancer, a serious disease that required immediate surgery to remove the tumor, followed by chemotherapy and radiation therapy. The surgery went smoothly at a local hospital, but afterward, the bills began to pour in like an uncontrollable tsunami. The ICU room for a few days cost up to $10,000. Surgery and surgeon fees were about $50,000. Medication and chemotherapy added another $30,000, not to mention specialist checkups, regular blood tests, and psychological counseling. Although the insurance company covered a large part, about 70 to 80% after they met the deductible. The remaining amount the family had to pay out of pocket was still enormous. The $5,000 deductible plus co-pays and non-covered costs amounted to over $40,000 in the first year alone. Sarah had to take a temporary leave from work for treatment, causing the family's income to drop while the monthly bills continued to accumulate. John and Sarah had to use up all their meager savings, borrow an additional $15,000 from friends and family, and finally remortgage their house to borrow another $50,000 from the bank. After 2 years of fighting, Sarah's illness was finally under control, and she could return to work part-time. But their family had changed forever. They lost their dream home because they couldn't make timely debt payments, lost all their savings for their old age and their children's education, and now had to live in a cramped rented apartment with a total debt of over $100,000 hanging over their heads. Their children had to witness their parents' stress, arguing about money, and John even had to work extra hours to compensate, leading to his own health decline. This is not a rare story. According to reports from organizations like the Kaiser Family Foundation, hundreds of thousands of American families fall into similar situations every year, where a single unexpected illness can wipe out the entire financial foundation they have built over decades. But inequality in the U.S. healthcare system is not limited to such personal stories. It is also a mechanism that amplifies deeper social stratification. This system was not built on a foundation of fairness, but seems to be designed to reinforce the gap between the rich and the poor. Studies from reputable organizations like the Centers for Disease Control and Prevention and the American Journal of Public Health show that people from lower classes, especially people of color, immigrants, and minority communities, often have less access to quality health insurance. They often work in low-wage jobs, such as manual labor, customer service, or agriculture, where health benefits are rarely provided. Furthermore, they also face systemic discrimination, such as longer waiting times at clinics or being denied certain services for administrative reasons. This creates a terrifying, vicious cycle. Poverty leads to poorer health due to malnutrition, polluted living environments, and lack of regular checkups. Then illness pushes them deeper into poverty through unaffordable treatment costs, job loss, and crushing debt. For example, according to a recent report, the uninsured rate for African Americans is twice as high as for white Americans, leading to significantly higher mortality rates from cardiovascular disease and cancer. Therefore, we cannot help but ask big and urgent questions. If health is a basic human right, why in the U.S. does it seem like a luxury item only for those who can afford it? Here you can buy health like you buy a luxury, Mercedes or a Hermes bag. The rich can instantly access top hospitals like the Mayo Clinic or Johns Hopkins, see the world's leading specialist doctors, and receive comprehensive care with the most advanced technology. In contrast, the poor, especially in rural or impoverished urban areas, often have to wait for months to be seen at an overcrowded public clinic, or worse, have to endure pain without timely treatment, leading to serious complications. This creates a surprising contrast to other countries. While Canada, the UK, or European countries see healthcare as a basic public service, just like free education or the fire department, where every citizen has access. Without worrying about costs, the U.S. views healthcare as a consumer product in a free market. We never ask a person to pay before the fire department puts out a fire in their house, or to prove their income for their children to go to school. So why do we accept a system that requires patients to pay before they can be saved, or even to go into debt to survive? The medical nightmare in the U.S. is not only a huge financial burden, but also a persistent psychological obsession, deeply affecting the mental health and daily quality of life of millions of people. The constant worry about potential illness and treatment costs can cause chronic stress, leading to depression, anxiety, and even other health problems like insomnia or high blood pressure. According to the American Psychological Association, more than 60% of Americans report that healthcare costs are the main source of stress in their lives, surpassing even work or relationships. This is especially serious for middle-aged people who have to balance caring for their children and elderly parents, while they themselves are also at a high risk of chronic diseases. In a country built on the promise of the American dream, where prosperity and opportunity are advertised as being for all, what happens when a single illness can take everything away? A home, savings, a future? Certainly, there have been efforts to change the situation from historical policies to recent reforms. We will explore those in the next part, where we will analyze healthcare reform efforts, bitter failures, and half-baked successes that have shaped the system today. Let's continue this journey to get a clearer understanding of the path forward. Failed reforms and partial successes. Welcome back to the journey of exploring the tumultuous American healthcare system. In the previous part, we witnessed the personal tragedies and deep injustice that this system causes, where illness is not just a health problem, but a heavy financial sentence. Did anyone stand up to change this situation? The answer is yes. But the path to healthcare reform in the U.S. has never been easy. It is a prolonged political battle, full of failures, half-baked successes, and powerful forces behind the scenes. Let's delve into two major milestones in the history of U.S. healthcare reform. The ambitious effort of the Clintons and the Affordable Care Act, also known as Obamacare. In the early 1990s, when President Bill Clinton took office, he carried with him an ambitious promise: to solve the healthcare crisis that was leaving millions of Americans living in fear of healthcare costs. Believing that the healthcare system needed a complete overhaul, he tasked First Lady Hillary Clinton with leading a special committee to develop a comprehensive reform plan. This plan, called the Health Security Act, was one of the most ambitious efforts in U.S. history to ensure every citizen had health insurance. The Health Security Act was designed to address the health insurance problem comprehensively. One of the main ideas was to create regional health alliances. These were intermediary organizations where small businesses, individuals, and families could buy affordable health insurance. This idea aimed to increase competition among insurance companies, reduce costs, and ensure that everyone, even those not provided with insurance by their company, could access medical services. In addition, the plan also required businesses to provide insurance for their employees and subsidize those with low incomes so they could afford to buy insurance. In theory, this was a promising plan. With the potential to change the entire landscape of U.S. healthcare, it not only aimed to expand coverage, but also tried to control soaring healthcare costs, a problem that both citizens and the government were struggling with. However, as soon as it was announced, the Clinton plan was met with a massive wave of opposition. Insurance companies, pharmaceutical corporations, and healthcare interest groups. The forces that were making billions of dollars from the current system saw this plan as a direct threat to their profits. They quickly organized a protest campaign on an unprecedented scale. One of the most powerful weapons of the opposition was the Harry and Louise advertising campaign. In this series of ads, a middle-class couple named Harry and Louise appeared in the familiar setting of their family kitchen, worriedly discussing the Clinton healthcare reform plan. They complained about the complexity of the new system, warning that the government would interfere too deeply in personal lives and reduce the quality of healthcare. These ads hit a nerve in the public's fear of change, especially the fear of a giant government controlling every aspect of life. The Harry and Louise campaign was funded by the Health Insurance Association of America, an organization representing insurance companies. With millions of dollars poured into TV ads, the campaign succeeded in sowing doubt and fear among the public. Many Americans who were already used to the current system, however imperfect, began to worry that the Clinton plan would make everything worse. Despite President Clinton's full-hearted efforts to lobby for the plan, he could not overcome the power of interest groups and the division within Congress itself. The Republican Party, along with some conservative Democrats, strongly opposed it. The plan became too complex to explain to the public, and the lack of unity within the Democratic Party further weakened its chances of success. In the end, the Health Security Act was never brought to a vote in Congress and died in 1994. This failure left a bitter lesson. The power of insurance corporations, pharmaceutical companies, and healthcare interest groups is an almost impenetrable wall. It also left a deep political scar, making many believe that comprehensive healthcare reform was an unattainable dream. It took nearly 2 decades for a new reform effort to be launched, but this time with a different approach. After the Clintons' failure, the healthcare issue remained an open wound in American society. Healthcare costs continued to soar, the number of uninsured people grew, and inequality and access to medical services became more apparent than ever. By 2008, when Barack Obama was elected president, he made healthcare reform one of his top priorities. After the 2007-2008 financial crisis, when millions of Americans lost their jobs and health insurance, the need for reform became more urgent than ever. In 2010, after months of heated debate and intense negotiation, the U.S. Congress passed the Affordable Care Act, commonly known as Obamacare. This was not a universal healthcare system, as many had hoped, but an effort to patch the biggest holes in the current healthcare system while expanding coverage and controlling costs. Obamacare brought about several landmark changes that helped millions of Americans, banning insurance denial for pre-existing conditions. Before the ACA, Insurance companies often refuse to provide insurance to people with a history of pre-existing conditions like diabetes, cancer, or heart disease. If accepted, they often had to pay exorbitant premiums. The ACA banned insurance companies from doing this, ensuring that everyone, regardless of their health status, could buy insurance. Medicaid expansion. The ACA expanded the Medicaid program, a public health insurance program for low-income people. As a result, millions of poor people in participating states could access free or low-cost medical services. Insurance marketplaces. The ACA created health insurance marketplaces where individuals and families could buy government-subsidized insurance plans. This was especially helpful for freelancers or those working for small companies that did not provide insurance. Insurance for young people. One of the most popular provisions of the ACA was allowing young people under 26 to stay on their parents' health insurance plan. This helped millions of young adults who were just out of school and didn't have stable jobs to remain protected. Insurance subsidies. The ACA provided income-based subsidies to help people pay for premiums, making insurance more affordable for middle and low-income families. The results of these changes were significant. The percentage of uninsured Americans dropped to a historic low, from about 16% of the population in 2010 to about 8% by the end of Obama's term. For the first time in their lives, millions of people had the peace of mind of knowing that they would not go bankrupt because of an illness. Despite achieving many successes, Obamacare was not a crawl. One of the biggest problems was that it did not solve the root problem of healthcare costs. Although they had insurance, many people still faced high premiums and deductibles, making them hesitant to use medical services. For example, a person with insurance might still have to pay thousands of dollars before their insurance starts to pay, which is especially difficult for middle-income families. In addition, the ACA depended on the cooperation of the states, and not all states participated in the Medicaid expansion. Some Republican-controlled states refused to expand the program, leaving millions of poor people in a coverage gap. They earned too much to qualify for Medicaid, but too little to afford insurance through the marketplace. Obamacare was not just a healthcare law, but also a fierce political battlefield. As soon as it was passed, it was seen by the Republican Party as a symbol of excessive government intervention. They called the ACA a step towards socialism and vowed to repeal and replace it. Throughout Obama's presidency, the Republican-controlled House of Representatives voted more than 60 times to repeal or weaken the ACA. But these efforts were often blocked in the Senate. One of the most dramatic moments occurred in 2017, when Senator John McCain, veteran Republican figure, voted against the effort to repeal the ACA, saving the law by a narrow margin. McCain's vote, cast just a few months before he died of cancer, became a symbol of the struggle for healthcare reform. Under President Donald Trump, efforts to weaken Obamacare continued. One of the biggest changes was the elimination of the individual mandate, the penalty for people who did not buy health insurance. This weakened the financial foundation of the ACA, as the law relied on having as many people as possible participate to keep costs low. In addition, the Trump administration also cut the budget for advertising and support for the insurance marketplaces, making it harder to access the ACA. When Joe Biden took office in 2021, his administration focused on strengthening and expanding Obamacare. A significant step was the Inflation Reduction Act in 2022, which for the first time gave Medicare the public health insurance program for the elderly, the right to negotiate the price of some drugs with pharmaceutical companies. This was a historic step, as it broke the power of drug companies to freely set drug prices. However, this measure only applies to a few expensive drugs, and its impact is still limited. If everyone from ordinary people to politicians agrees that the U.S. healthcare system has problems, why is it so difficult to fix? The answer lies in the complexity of the system and the power of the interest groups behind it. The power of interest groups, insurance companies, pharmaceutical corporations, medical organizations like the American Medical Association have huge financial resources and professional lobbying teams. They spend billions of dollars each year to protect their interests, from funding election campaigns to advertising and lobbying for policies. Political division. Healthcare reform is a deeply politicized issue. While the Democratic Party supports government intervention to expand insurance and control costs, the Republican Party often sees this as an infringement on individual freedom. This polarization makes achieving consensus almost impossible. The complexity of the system. The U.S. healthcare system is a complex network of private insurance companies, hospitals, doctors, and government agencies. Any change, no matter how small, can cause a domino effect, affecting millions of people and billions of dollars. Fear of change. Many Americans, although unhappy with the current system, are still afraid that reform will make them lose what they have. Campaigns like Harry and Louise exploit this fear, making the public skeptical of major changes. From the Clintons' failure to the half-baked successes of Obamacare, the history of U.S. healthcare reform is a story of ambition, struggle, and compromise. Although the ACA has helped millions of people get health insurance, it has not yet solved the core problem: exorbitant healthcare costs and inequality in access to services. The hidden forces, from insurance companies to pharmaceutical corporations, continue to play a big role in shaping the game. In the next part, we will uncover these forces. Who really controls the U.S. healthcare system? How have they manipulated policies to maintain their huge profits? And is there any hope for a fairer healthcare system in the future? Stay with me to find out. Big Pharma, insurance giants, and the political game. Welcome back to the journey to explore the complex hidden corners of the American healthcare system. In the previous parts, we witnessed ambitious reform efforts get stuck in a political quagmire with no way out. A series of questions arise. Why is a problem that everyone clearly sees, expensive healthcare costs, inequality in access to services, so difficult to solve? Who are the people behind the scenes, pulling the strings and making every attempt at change seem hopeless? The answer lies in two giant forces: pharmaceutical corporations and insurance companies. They are not just participants in the healthcare system, but also the ones who write the rules, shape the game, and protect their interests at all costs. Let's start with pharmaceutical corporations, the giants that dominate the U.S. healthcare industry. Big Pharma not only manufactures drugs, they also hold almost absolute power to price their products, while many other developed countries, like Canada or European countries, have mechanisms to negotiate drug prices with the government to ensure reasonable prices and public access. In the U.S., the federal government does not have this right. The law prohibiting the government from negotiating drug prices with pharmaceutical companies, a rare privilege in the world, has created a playing field where Big Pharma can freely impose exorbitant prices. Look at a specific example: a treatment course for hepatitis C, such as the drug Sovaldi, can cost up to $84,000 for a 12-week course in the U.S. Meanwhile, in countries like India or Europe, the price of the same drug is only a fraction, sometimes just a few $1,000s. Why is there such a huge difference? The answer lies in the U.S. patent system, which grants drug companies a monopoly on manufacturing and distributing a drug for many years. During this time, they can freely set prices without worrying about competition when a drug becomes a matter of life and death. Like a drug to treat cancer, diabetes, or chronic diseases, accepting the price becomes an unavoidable choice for the patient. But Big Pharma doesn't just stop at high pricing. To protect their huge profits and power, they invest billions of dollars in political lobbying. Statistics show that the pharmaceutical industry is one of the biggest spenders on lobbying in Washington, D.C. With hundreds of millions of dollars poured into persuading members of Congress and government officials each year, their goal is very clear: to prevent any law that could lower drug prices, allow the government to negotiate prices, or increase competition from generic drugs. They fund election campaigns, host lavish events, and even hire former government officials as lobbyists for themselves, creating a network of deep and almost unbreakable influence. Besides Big Pharma, insurance companies are also a force not to be underestimated in the U.S. healthcare system. They don't directly produce drugs or provide medical services, but their role is that of a gatekeeper, controlling almost every aspect of access to healthcare. Insurance companies decide which services are covered, which doctors are in their network, and what patients are allowed or not allowed to do. This power gives them a special position, but also creates serious conflicts of interest. The profits of insurance companies come from collecting high premiums from customers while paying out as little as possible for claims. In other words, they make money by minimizing patients' ability to receive the medical services they have paid for. To achieve this goal, insurance companies have built a huge administrative apparatus, thousands of employees who do one thing: find ways to deny or delay claims. If you have ever spent hours on the phone with your insurance company to argue about a medical bill, or have been denied coverage for a procedure you thought was necessary, you are not alone. Millions of Americans face frustration, helplessness, and sometimes despair when trying to overcome the barriers set up by insurance companies. Like Big Pharma, insurance companies also spend heavily on lobbying. They pour money into political campaigns, fund members of Congress, and use their influence to maintain a healthcare system where profits are prioritized over people's health. They oppose any reforms that could reduce their control, such as proposals for public health care or regulations requiring more transparency in how they handle claims. When Big Pharma and insurance companies join hands, the American political system becomes a battlefield where large interest groups clash. While the interests of ordinary citizens are pushed to the sidelines, campaign contributions, lobbying contracts worth millions of dollars, and a phenomenon called the revolving door, where government officials become lobbyists for the very companies they once regulated after leaving office, have created a system that is almost invulnerable. Look at Obamacare, one of the biggest reform efforts in U.S. healthcare history. Although the law helped millions of Americans get health insurance, it still faced countless legal battles, repeal attempts, and non-stop opposition from interest groups like Big Pharma and insurance companies. These forces not only protected their profits but also ensured that any changes had to pass through their lens, making genuine reforms more difficult than ever. The consequence of this deadlock is a healthcare system where costs are constantly increasing, but quality and access are not commensurate. Insurance companies continue to charge high premiums, Big Pharma continues to price drugs at an unthinkable level, and Americans are stuck between the lines of a system that prioritizes profit over health. All of these factors lead to an unacceptable paradox. The U.S. is the country that spends the most on healthcare globally, but its results are far behind other developed countries. According to recent data, per capita healthcare spending in the U.S. is about $12,000 per year, nearly double that of OECD countries like Germany, Canada, or Japan. However, the average life expectancy of Americans is lower. The mortality rate from preventable diseases is higher, and many people cannot access basic medical services just because they cannot afford them. Americans' money is not being invested in disease prevention or improving public health. Instead, it flows into the pockets of Big Pharma through exorbitant drug prices, into huge bonuses for insurance company CEOs, and into lobbying campaigns to maintain the status quo. This system is not only inefficient, but also deeply unjust. Health, which should be a basic human right, has become a privilege only for those who have enough money. This injustice raises a big question. Is there a glimmer of hope to change the American healthcare system? Technology could be the key to breaking this deadlock, with innovations like telemedicine, artificial intelligence in diagnosis, or platforms that transparently show healthcare costs. But are these solutions strong enough to confront giants like Big Pharma and insurance companies? Or will health forever be a luxury item, only for those who can afford it? The answer is not simple, but one thing is for sure. To change this system, more is needed than half-baked reforms. It requires political will, public participation, and perhaps a change in the way we view the value of human health. In the next part, we will explore potential solutions, technology to social movements, and see if they can bring a fairer future to the U.S. healthcare system. Stay tuned. What is the future of us healthcare? Welcome to the final part of our journey to explore the American healthcare system, a story full of emotions, From historical advances to stunning numbers, personal tragedies, and political battles that seem to never end. Now that we have peeled back each layer of this system, it is time to turn our eyes to the future. Is there a way out of the intractable problems of U.S. healthcare? Is technology really the key to breaking the deadlock? Or will health forever be a privilege only for those who can afford it? Let's delve into the possibilities, challenges, and big questions that are shaping the future of the U.S. healthcare industry. In the chaos of the current healthcare system, technology stands out as a guiding light, promising to bring innovative solutions. The three main technology trends shaping the future of U.S. healthcare are artificial intelligence, telemedicine, and digital insurance. These technologies not only have the potential to improve the efficiency and quality of care, but can also reduce costs, increase accessibility, and bring more fairness to the system. AI is rapidly becoming a powerful tool in healthcare, with the ability to solve many of the system's core problems. First, AI helps with more accurate diagnoses. It can analyze medical images like X-rays, MRIs, or CT scans with superior accuracy, sometimes detecting abnormalities that the human eye might miss. For example, AI algorithms have been shown to detect early-stage breast or lung cancer with accuracy equal to or higher than specialists, helping to save many lives and reduce long-term treatment costs. In addition, AI also promotes personalized medicine by analyzing large data from medical records, genetics, and patient lifestyles to create tailored treatment plans, optimizing effectiveness and minimizing side effects. For instance, in cancer treatment, AI can predict how a patient will respond to a specific drug, helping doctors choose the best method. Finally, AI can automate administration. One of the biggest burdens of the U.S. healthcare system is the huge administrative cost, which accounts for up to 8% of the national healthcare expenditure. AI can automate processes like billing, claims processing, and patient record management, helping to minimize errors and save billions of dollars. If implemented correctly, AI could be the key to making the healthcare system not only more efficient, but also more humane, focusing on saving lives instead of chasing profits. The COVID-19 pandemic accelerated the development of telemedicine, turning it from a new idea into an indispensable part of the healthcare system.
Oh, my very much.
Remote doctor visits allow patients to connect with doctors via video or phone, eliminating the need to travel to medical facilities, which is especially important for people living in rural areas or areas with a shortage of specialists. Telemedicine helps save money for both patients and providers. Patients don't have to pay for travel, taking time off work, or other related costs, while hospitals and clinics also reduce operating costs by not needing to maintain so many physical facilities. In addition, it also increases accessibility. In the U.S., millions of people live in areas called medical deserts, where there is a shortage of doctors and hospitals. Telemedicine helps bridge this gap, bringing healthcare services directly to patients' homes. From mental health counseling to chronic disease management, in particular, telemedicine is very useful in primary care, helping to detect health problems early before they become serious. The explosion of telemedicine is not just a temporary solution during the pandemic, but also a sustainable model for the future. It's promising to make healthcare more accessible and less expensive. The health insurance system in the U.S. today is a complex maze, with claims processes that are often long and prone to disputes. Digital insurance technology and blockchain can change this. First, it can automate claims processing. Digital platforms using AI and blockchain can process these claims almost instantly, minimizing errors and fraud. Blockchain ensures transparency by storing transaction data on an immutable ledger, helping both patients and providers trust the system. This technology also helps reduce administrative costs. The cost of processing insurance claims in the U.S. today is one of the main reasons for skyrocketing healthcare spending. Digital platforms can significantly reduce this cost, freeing up resources to be invested in patient care. Finally, it empowers patients. With more transparent data, patients can easily understand their insurance benefits, avoiding unpleasant surprises like surprise billing. If widely implemented, these technologies could transform the U.S. healthcare system into a more efficient machine. where patients are put first instead of being stuck in a spiral of profit and bureaucracy. Although technology offers many promises, it is not a cure-all. The U.S. healthcare system is not just a technical problem, but a deep political and economic one. The biggest barriers come from interest groups and the politicization of the healthcare industry. Try to put yourself in the shoes of large pharmaceutical corporations or insurance companies. These organizations make hundreds of billions of dollars each year from the current system, which is based on complexity and high costs. Technology could threaten their business model. If AI helps develop new drugs faster or optimizes production processes, drug prices could fall. But what incentive does Big Pharma have to support this when their profits depend on keeping drug prices high? Similarly, if telemedicine reduces the need for hospitalization or expensive procedures, large hospitals will lose a huge source of income and may oppose the expansion of telemedicine. Insurance companies also often profit from the lack of transparency in the claims process. A more transparent digital system could reduce their profits, making them resistant to such reforms. Healthcare and insurance corporations in the U.S. spend billions of dollars each year on lobbying, ensuring that healthcare policies serve their interests. According to Open Secrets in 2024, the pharmaceutical and health insurance industries spent over $700 million on lobbying activities, far exceeding any other industry. This power allows them to influence legislative decisions, blocking reforms that could hurt their profits, even when they would benefit millions of citizens. For example, the idea of a universal healthcare system has been strongly opposed by these interest groups for decades. They argue that this system would reduce people's freedom of choice, but in reality, their main goal is to protect their profits. As a result, any reform effort must face a political wall that is almost impossible to break. Besides economic interests, there is also a deep cultural barrier. The mindset that healthcare is a commercial product, not a basic right. In the U.S., the concept of individual freedom is often associated with paying for medical services oneself, rather than relying on the government. This mindset makes many people oppose universal healthcare models, even when they face huge medical bills or the risk of bankruptcy due to treatment costs. The future of the U.S. healthcare system will follow one of two clear paths, each with profound consequences for society. One is the universal healthcare path. This is the model that most developed countries in the world have adopted, from Canada to Germany, Japan to the United Kingdom. In the U.S., this model could be implemented in the form of a single-payer system, such as expanding the Medicare program to cover the entire population, or a hybrid system with the participation of both the public and private sectors, but tightly regulated by the government. The benefit of this model is equal access for every citizen, ending the situation where millions of Americans are uninsured. It also helps reduce administrative costs by eliminating the complexity of private insurance companies, saving hundreds of billions of dollars a year. Furthermore, with universal access to healthcare, more people will receive care earlier, focusing on prevention, which reduces the rate of severe illness and long-term treatment costs. However, the major challenges are political opposition from interest groups, the need to increase taxes to fund the system, and a cultural shift from healthcare as a commercial product to a basic right. The second is the for-profit healthcare path. This is a continuation of the current system, where healthcare is seen as a competitive market and health is a luxury item. The benefit of this path is rapid innovation, especially in fields like medical technology and pharmaceuticals. Consumers can choose the doctor, hospital, or insurance plan that suits their needs, providing freedom of choice. However, the negative consequence is increased inequality. The rich will receive better care than ever before, while tens of millions of poor or middle-class people will struggle with expensive plans, limited benefits, and the risk of bankruptcy from medical bills. Costs will continue to skyrocket, and companies will focus on profit instead of patients. Our journey through the American healthcare system has revealed a complex picture, a system that began with simple ideas but has become a huge machine, full of contradictions and injustice. This is not just a story about money or policy, but also a struggle to redefine the nature of human health. Is health a basic right that everyone should have, or is it a luxury item only for those who have enough money? The final question I want to leave you with is, will there ever be a day when Americans can go to the doctor like they go to school, without worrying about the cost, without fear of being denied service, and without being pushed into debt just for wanting to be healthy? Or will health forever be a privilege only for the upper class? Ponder this and share your thoughts. Which path do you think universal healthcare, or for-profit healthcare, will be the future of the U.S.? And how can we balance technological innovation, economic interests, and social justice?
You've crossed the story. You felt every pulse in the dark, and I was there with you, quietly, always. That's why I left behind one last thing. Not to explain, not to impress, just to stay with you a little longer. A song I chose with care, as if tucking you in from across time and space. So go on, lay back, the music knows where to take you.